All right, scenario 3. Let's see. All right, and let's look at this. This is, I even gave y'all some, I gave this tip. This is something I just put in here as I was doing the rationales and all yesterday. Remember that reportable diagnoses references diagnoses associated with the patient's nutritional status. So our ICD-10-CM guideline tells us that BMI codes should only be assigned when there is an associated reportable diagnosis, such as obesity. Now that the guidelines give us that, but they don't restrict us to only obesity. What they're saying is any associated diagnosis that we're going to report in our coding, and there is a BMI available in that chart, we can code that. Okay. All right, so let's look at our patient. This is a 61-year-old female with a past medical history. She has chronic diastolic heart failure. She has obstructive sleep apnea, major depressive disorder, and anxiety. She's being admitted because of melanotic stools. It was determined that because of this bleeding, that they would do an endoscopy. So the endoscopy note tells us that it was passed into the esophagus, the stomach, and the duodenum. There was blood noted. The patient could possibly have a duodenal ulcer, but because of the amount of the blood, it was difficult to delineate an ulcer crater. All right, so our discharge diagnoses from the physician: melanotic stools, possible duodenal ulcer. Our BMI is 19.2. The patient has severe protein calorie malnutrition. Chronic diastolic heart failure, well maintained. Obstructive sleep apnea, major depression disorder, and anxiety. We're not going to code this possible duodenal ulcer because it's possible. In the outpatient world, we do not code possible diagnoses, uncertain diagnoses. So we're going to code our melanotic stool. We're also going to pick up our other chronic diseases. Our guideline tells us that chronic diseases treated on an ongoing basis may be coded and reported as many times as the patient receives treatment and care. We don't really know what care was given, but we know that when he documented his discharge diagnosis, he made mention of these. So you all picked up that. You all picked up these diagnoses. We coded the K92.1, that was for our melena. And then we coded our I50.32 for our chronic diastolic heart failure, our G47.33, our F32 depression, F41.9 anxiety, and we should have picked up Z68.1 because we have E43 here. We have the diagnosis reported severe protein calorie malnutrition, and that is a nutritional diagnosis. And a BMI of 19.2 should have been assigned because we have a reportable diagnosis. Okay, so I made a note for all of you to do. I'm just going to bold it so that when you get this email, let's see if I can pick up Find a Code for us right here. And let's just go to E43. And in our common language description, if we notice here, we have a lot of information here. And then when it talks about this specifying the severity, There are no official guidelines to determine the level of severity, but there are some generally accepted parameters based on physical findings, risk factors, biochemical markers, and your body mass composition. So we can see here that the body mass composition is an indicated recent or progressive unintended weight loss. And so we have our 19, our Z, let's look that up. That's a BMI of 19.9 or less. That's pretty low. The BMI for adults, it even gives us this here, is 20 for persons 20 years of older. This is what we would use for this specific patient. If we look down here at 19, we're going to see it's a 19 point. It falls under the normal. But we can use this in conjunction with any of these codes in the E40 category. So we can do a little bit of homework in the common language descriptions and find a code, which I'll tell you I love, because in the code books you don't have that. So more than likely you will use a code book in conjunction with an encoder to give you the education that you need to be able to understand. So on this specific scenario number 3, we did great. Let's see, everybody got the procedure, which was, if we go down here, this endoscopy. And the only thing I want to point out on that is when you have an endoscopy, you want to pay attention to the documentation of where that scope was able to view. This scope went into the stomach and duodenum, because you know that determines the extent of the exam and determines our code. Question, you all got that. So I felt really comfortable that we understood that even though the physician said esophagoscopy, that what we coded, if we go and we look that up, as our 43235, we see that it's an EGD, an esophagogastroduodenoscopy. But you all got that. Blessing, you have a question?
Yes.
Okay, what is it?
So in the real world, actually I didn't include the BMI. So in the real world, what is the effect of not including the BMI? What can be the possible effects of not putting that in the code?
There's no financial impact. There's no financial. If you have an auditor come in, they're going to ding you. They're going to say, he should have coded the BMI. But as far as financial impact for your provider that you're coding for, there is none. But what you want to be able to understand and remember through time is that you do code it. It is important. Whether or not that BMI is severely low or not, we have an instructional note at that E40 category that we can use the BMI. We have an official guideline tells us that when it should be assigned. So when I'm being audited by an auditor, I want to make sure that all my I's are dotted and my T's are crossed. So you want to pick it up for correct coding. For financial impact, 0.
Thank you.
You're welcome. Okay. You ready to go to number 4?
Yes.
Okay. So when y'all get this, just take time to read, because I wrote a lot. I wrote a lot this time.